Hi, this is Dr. Shepard. Today's presentation focuses on anxiety disorders from a clinical, practice-oriented perspective, with an emphasis on recognition, efficient screening, and evidence-based treatment. Anxiety disorders are among the most common conditions you will encounter across all settings, particularly in inpatient psychiatry, primary care, and integrated behavioral health, and they frequently present alongside depression, substance use disorders, and medical conditions. Rather than approaching anxiety as a single diagnosis, it is important to recognize that it represents a spectrum of disorders with distinct underlying mechanisms, symptom patterns, and treatment approaches. As advanced practice nurses, your role is not only to identify anxiety, but to differentiate between disorders such as generalized anxiety disorder, panic disorder, obsessive-compulsive disorder, and trauma-related disorders, as this directly informs treatment selection. This lecture is designed to be highly practical. We will focus on how to rapidly screen for anxiety disorders, how to distinguish them clinically, and how to initiate treatment safely and effectively, particularly in complex patients with comorbidities such as substance use. The goal is to move beyond recognition into confident clinical decision-making so that you can apply these concepts immediately in practice. Start by identifying the core symptom pattern the patient is experiencing and match that to diagnostic criteria. For generalized anxiety disorder, look for excessive anxiety and worry occurring more days than not for at least 6 months, about multiple domains such as health, finances, or relationships. The key feature is that the patient finds the worry difficult to control, and it is accompanied by symptoms such as restlessness, fatigue, poor concentration, irritability, muscle tension, or sleep disturbance. For panic disorder, assess for recurrent, unexpected panic attacks, defined as abrupt surges of intense fear or discomfort that peak within minutes. During these episodes, patients experience symptoms such as palpitations, shortness of breath, chest pain, dizziness, or fear of dying. Diagnosis also requires at least 1 month of persistent concern about additional attacks or maladaptive behavioral changes, such as avoidance. For obsessive-compulsive disorder, identify the presence of obsessions, compulsions, or both. Obsessions are intrusive, unwanted thoughts or urges that cause distress, while compulsions are repetitive behaviors or mental acts performed to reduce that distress. These must be time-consuming or cause significant impairment. For post-traumatic stress disorder, confirm exposure to a traumatic event and the presence of symptoms across 4 domains: intrusion, avoidance, negative alterations in cognition and mood, and hyperarousal. Symptoms must persist for more than 1 month and result in functional impairment. For specific phobia, look for a marked and persistent fear of a specific object or situation, such as flying, heights, animals, or medical procedures, that is out of proportion to the actual threat. The fear leads to avoidance or is endured with intense distress and must interfere with functioning. Approaching screening this way allows you to move quickly from symptom recognition to diagnostic reasoning rather than relying on vague or nonspecific questions. Obsessive-compulsive disorder is defined by the presence of obsessions, compulsions, or both, and it is important to clearly distinguish these from general anxiety or worry. Obsessions are intrusive, unwanted thoughts, urges, or images that cause significant distress. Common themes include contamination, harm, symmetry, or taboo thoughts. A key feature is that the patient recognizes these thoughts as their own, but experiences them as difficult or impossible to control. Compulsions are repetitive behaviors or mental acts performed in response to obsessions, with the goal of reducing anxiety or preventing a feared outcome. Examples include excessive hand-washing, checking, counting, or repeating actions. These behaviors are not realistically connected to what they are intended to prevent, or they are clearly excessive. For diagnosis, these symptoms must be time-consuming, typically more than 1 hour per day, or cause significant distress or impairment in functioning. Clinically, patients often have insight, but the degree can vary, and this affects both prognosis and treatment engagement. It is critical to differentiate OCD from generalized anxiety disorder. In generalized anxiety disorder, the thoughts are typically real-life worries, whereas in OCD, the thoughts are intrusive, often irrational, and accompanied by compulsive behaviors. From a treatment perspective, first-line interventions include high-dose SSRIs and exposure and response prevention, ERP, a specialized form of cognitive behavioral therapy. In exposure and response prevention, patients are gradually exposed to the feared thought, object, or situation, while intentionally refraining from performing the compulsion, allowing anxiety to decrease over time through habituation. Finally, remember that OCD is often underdiagnosed because patients may feel embarrassed or fear being judged, so direct, non-judgmental questioning is essential. Panic disorder is defined by recurrent, unexpected panic attacks, which are abrupt surges of intense fear or discomfort that peak within minutes. These episodes are characterized by prominent physical symptoms, including palpitations, shortness of breath, chest pain, dizziness, sweating, and a sense of impending doom or fear of dying. Because of this, patients frequently present to emergency or primary care settings believing they are experiencing a cardiac or respiratory event. For diagnosis, at least one of these attacks must be followed by 1 month or more of persistent concern about additional attacks or maladaptive behavioral changes, such as avoidance of situations where escape might be difficult or help unavailable. This anticipatory anxiety and avoidance behavior are what distinguish panic disorder from isolated panic attacks. A critical component of your role is medical rule-out. Before confirming a psychiatric diagnosis, you must consider conditions such as cardiac arrhythmias, thyroid dysfunction, pulmonary disorders, or substance-related causes, as these can present with similar symptoms. It is also important to differentiate panic disorder from generalized anxiety disorder. Panic disorder involves episodic, acute surges of anxiety, whereas generalized anxiety disorder is characterized by chronic, persistent worry. From a treatment perspective, first-line options include SSRIs and cognitive behavioral therapy, particularly interventions that address catastrophic misinterpretation of bodily sensations. When initiating SSRIs, start at a low dose and titrate slowly, as these patients are often sensitive to activating side effects, which can initially worsen anxiety symptoms. Finally, patients frequently develop avoidance behaviors, which can significantly impair functioning. Early identification and treatment are essential to prevent progression into more disabling patterns, such as agoraphobia. Post-traumatic stress disorder is defined by exposure to a traumatic event, followed by symptoms across 4 domains. A helpful way to organize these clinically is the mnemonic RANA, re-experiencing, avoidance, negative alterations in cognition and mood, and arousal. Re-experiencing includes intrusive memories, nightmares, or flashbacks, where the patient may feel as though the event is happening again. Avoidance involves efforts to avoid trauma-related thoughts, feelings, people, or places. Negative alterations in cognition and mood include persistent negative beliefs about oneself or the world, distorted blame, emotional numbing, and decreased interest in activities. Arousal symptoms include hypervigilance, exaggerated startle response, irritability, sleep disturbance, and difficulty concentrating. For diagnosis, symptoms must persist for more than 1 month and cause significant distress or impairment. It is important to distinguish PTSD from acute stress disorder, where symptoms occur within the first month following trauma. From a treatment perspective, first-line interventions include trauma-focused psychotherapy, such as trauma-focused cognitive behavioral therapy, or EMDR, along with SSRIs like sertraline or paroxetine. Prazo-WZN may be used as an adjunct for trauma-related nightmares. Always assess for comorbid conditions, including depression, substance use, and suicidality, as these are common and significantly impact both prognosis and treatment planning. Generalized anxiety disorder is characterized by excessive anxiety and worry occurring more days than not for at least 6 months, about a variety of domains such as health, finances, work, or family. The key diagnostic feature is that the patient finds the worry difficult to control, and it often feels constant or pervasive rather than situational. This anxiety is accompanied by at least 3 associated symptoms, including restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. These symptoms reflect both cognitive and physical components of anxiety, which is why patients may present with complaints such as chronic tension, headaches, or insomnia rather than identifying anxiety directly. A critical distinction is that generalized anxiety disorder involves chronic, persistent worry, whereas disorders like panic disorder involve episodic surges of intense anxiety. This distinction helps guide both diagnosis and treatment. From a treatment perspective, first-line options include SSRIs, SNRIs, and cognitive behavioral therapy. Buspirone may be considered particularly in patients with a history of substance use, as it is non-sedating and non-addictive. Hydroxyzine can be used for short-term symptom relief, though sedation may limit its use. Benzodiazepines should be used cautiously, if at all, particularly in patients with comorbid substance use, due to the risk of dependence. The goal of treatment is not to eliminate all worry, but to reduce it to a level that is manageable and no longer impairing functioning. Management of anxiety without benzodiazepines is a critical skill, particularly in patients with comorbid substance use, older adults, or those at risk for dependence. The goal is to use effective, evidence-based alternatives that address both acute symptoms and long-term anxiety control. First-line treatment remains SSRIs and SNRIs, which are effective across multiple anxiety disorders, including generalized anxiety disorder, panic disorder, and PTSD. These medications target the underlying neurobiology of anxiety but require time to take effect, so patient education is essential to set expectations. For more immediate symptom relief, hydroxyzine can be used as a non-addictive option. It works quickly and can be helpful for acute anxiety, though sedation is a common side effect. Buspirone is another option, particularly for generalized anxiety disorder. It is non-sedating and non-habit forming, but requires consistent dosing and may take several weeks for full effect. Pregabalin may be considered in certain cases, especially when anxiety is severe or refractory, but it should be used cautiously due to potential misuse, particularly in patients with a history of substance use. In addition to medications, psychotherapy, especially cognitive behavioral therapy, is essential and should be offered whenever possible. In addition, beta blockers such as propranolol may be useful for situational anxiety, particularly when physical symptoms like tachycardia or tremor are prominent, such as in performance-related settings. However, they do not treat the underlying anxiety disorder and should be used selectively. Quetiapine may be considered in certain refractory cases of generalized anxiety disorder, but it is not a first-line treatment due to risks of sedation and metabolic side effects, and its use should be approached cautiously. Non-pharmacologic strategies such as relaxation techniques, sleep regulation, and reduction of caffeine and other stimulants also play a key role. The overarching principle is to treat anxiety in a way that is safe, sustainable, and minimizes risk, particularly in vulnerable populations where benzodiazepines may cause more harm than benefit. Regarding TCAs and MAOIs, these older agents do have demonstrated efficacy, particularly for panic disorder and PTSD, but they are rarely used as first-line today due to their side effect burden, lethality and overdose with TCAs, dietary restrictions with MAOIs, and significant drug interaction risk. Reserve them for treatment-resistant cases when first and second-line options have failed. Benzodiazepines provide rapid relief of acute anxiety, but they should be used intentionally and for a clearly defined purpose. In practice, if you are starting an SSRI for panic disorder or severe anxiety, you may consider a short-term bridge such as clonazepam 0.25 to 0.5 milligrams twice daily for 1 to 2 weeks while waiting for the SSRI to take effect. This should always be paired with a clear discontinuation plan from the start. Avoid initiating benzodiazepines in patients with current or past substance use disorders, as the risk of misuse and dependence is high. Also, avoid use in older adults, where these medications increase the risk of falls, cognitive impairment, and delirium. If a patient is already taking a benzodiazepine, assess dose, duration, and dependence. For example, daily use beyond a few weeks increases the likelihood of physiologic dependence. In these cases, do not stop abruptly. Instead, convert to a longer-acting agent such as diazepam or clonazepam if needed, and begin a gradual taper, typically reducing the dose by 10 to 25% every 1 to 2 weeks, depending on tolerance. Short-acting agents like Xanax should generally be avoided due to rapid onset, higher misuse potential, and interdose withdrawal, which can actually worsen anxiety between doses. Always document your indication, duration, and exit strategy. The goal is not just symptom relief, but to transition patients to safer, long-term treatments, such as SSRIs, SNRIs, and psychotherapy. Anxiety disorders are among the most common conditions you will encounter, and effective management begins with accurate differentiation between disorders, not just identifying that anxiety is present. Distinguishing between chronic anxiety, such as generalized anxiety disorder, and episodic conditions like panic disorder, or disorders driven by intrusive thoughts such as OCD, is essential because treatment strategies differ significantly. Screening should be efficient but purposeful. Use targeted questions and then align symptoms with DSM-5 criteria to guide diagnosis. Always consider medical and substance-related causes first, particularly in patients presenting with new onset or atypical symptoms. First-line treatment for most anxiety disorders includes SSRIs, SNRIs, and cognitive behavioral therapy, with psychotherapy playing a central role in long-term outcomes. When medications are used, start low, titrate slowly, and set clear expectations with patients regarding onset of effect. Benzodiazepines should be used cautiously and selectively, if at all, with a clear indication, short duration, and an exit strategy. Prioritize safer alternatives such as buspirone, hydroxyzine, or targeted use of beta blockers when appropriate. Finally, always assess for comorbid conditions, including depression, PTSD, and substance use disorders, as these significantly impact both treatment selection and prognosis. The goal is not simply to reduce anxiety symptoms, but to provide safe, sustainable, and individualized care that improves overall functioning. The references for this presentation are drawn from current clinical resources, including the DSM-5 and evidence-based guidelines reflected in the Hospital Psychiatry Factbook, which emphasizes practical approaches to assessment and management of anxiety disorders in real-world settings. As advanced practice nurses, it is important to move beyond memorization of criteria and instead focus on integrating evidence into clinical decision-making. Anxiety disorders are highly treatable, but outcomes depend on accurate diagnosis, appropriate treatment selection, and careful monitoring over time. As you move into clinical practice, focus on developing a structured approach. Identify the pattern of anxiety, rule out medical and substance-related causes, initiate first-line treatment, and then reassess and adjust based on response. These are the same steps you will use in both practice and any evaluation settings. The goal is to build confidence in your ability to recognize, differentiate, and manage anxiety disorders safely and effectively.